Good evening, ladies and gentlemen, colleagues. On behalf of my colleagues in the organizing committee of Dubai Pediatric Club, I would like to welcome all of you from Dubai, Abu Dhabi, UAE, other GCC countries, and all countries across the globe to this webinar. This webinar is entitled Pediatric Rheumatology. It's conducted in collaboration with NMC Specialty Hospital, Al Nahda, Dubai, and is sponsored by Vita Biotics, New Country Health, UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali, who is always helping us. Well, as I said, today's topic is pediatric rheumatology. We have an eminent speaker. Our speaker is Dr. Kamran Mahmood. Yeah. Our speaker is Dr. Kamran Mahmood. Dr. Kamran Mahmood is senior pediatric and adolescent rheumatologist. He'll be talking on mimickers of juvenile idiopathic arthritis. In a short while, I'll be introducing him. Dr. Kamran is at Sheikh Khalifa Medical City, Abu Dhabi. I'm chairing the session, and our moderators are Dr. Kalpana Sengupta, Secretary of the club, and Dr. Diari Muhammad, Chairman of the Academic Affairs. Well, as usual, there is a question for the viewers. I would like to request the viewers to just name these two pioneers in the field of pediatric rheumatology. If you mention the name and their contribution, the name will be announced and a token of appreciation will be given. This is just for 2 minutes. Well, beautiful Dubai. A view of Sheikh Zayed Road, on the background Burj Khalifa. Those who have not seen, please come and see this beautiful city. Well, Sheikh Zayed Road, day and night. You see here, Museum of the Future on the background, Burj Khalifa, Twin Towers, beautiful view of the Sheikh Zayed Road. Those who have not seen, we request them to come and visit. Well, members of Dubai Pediatric Club from beginning, from black and white era, and from the first and second conference, fourth and fifth conference, ninth and 10th conference, on behalf of all of them and on behalf of the organizing and executive committee of the Dubai Pediatric Club, well known to all of you, I would like to welcome you to this webinar. Well, I would like to request our viewers to save the date. Our 10th annual Dubai Pediatric Club Symposium will be held on Friday, 22nd November 2024. The venue will be announced. We will have eminent speakers and panelists. Well, our sponsor, Dr. Tawfiq, looking towards the Bombay and Bollywood. Well, I'll give a very brief account of history of pediatric rheumatology. Always I start with Hippocrates. As I say, everything starts with Hippocrates and ends in Hippocrates. In 460 BC, Hippocrates described the rheumatology feature in children. You can see in this article in 2004, Clinical and Experimental Rheumatology. You can find what Hippocrates said. Well, Al-Razi, the father of pediatrics, in 9th century, he described measles. Still, we have difficulty in diagnosing clinically. Well, Guillaume de Baillou, in French it is called Guillaume, is considered the father of rheumatology. He first used the term rheumatism to refer to joint ailments in 16th century. Well, about history of rheumatology, 13 physicians, including 2 Nobel laureates in 1932, held the first meeting of American Committee for Control of Rheumatism. In 5 years, it became the American Rheumatic Association. Pediatric rheumatology was formally recognized as a specialty in 1991 by American Board of Pediatrics. Well, the scientists in our question, now we stopped receiving any answer. Well, Dr. Cassidy and Dr. Bywaters are a few words I will tell about them. Well, the gentleman you see here is Dr. Eric Bywaters. The first American Rheumatic Association conference on rheumatic diseases of children was held in Park City, Utah, United States in 1976. And in this meeting, Dr. Eric Bywaters, he laid the foundation of pediatric rheumatology. Dr. Eric Bywaters, widely acknowledged as one of the great innovators in British rheumatology. So in British rheumatology, remember Dr. Eric Bywaters. Well, here you see the first meeting of the pediatric rheumatologists, 59 participants pictured in the Treasure Mountain in Park City, Utah in 1976 when the first formal inauguration was held. The formal inauguration of a specialty took place in 1976. As I said, when American College of Rheumatology sponsored the conference Pediatric Rheumatic Diseases. So from there, things started. Well, in the UK, pediatric rheumatology was first imaged in the UK with the establishment of Medical Research Council Rheumatism Units in way back 1947. Based in Taplow, UK, the unit was directed by Professor Eric Bywaters. In 1950s, under the dual leadership of the Professor Bywaters and Dr. Barbara Ansel, Taplow became an international center for the treatment of children with chronic arthritis in 50s, you please note. Well, in America, Dr. James Cassidy was considered the father of pediatric rheumatology. Cassidy was internationally recognized for his work in pediatric rheumatology and wrote the first textbook, as you see here, called Textbook of Pediatric Rheumatology. So he is a pioneer in America. Well, our hero here, Dr. Kamran Mahmood. Well, today's webinar, as I said, is about pediatric rheumatology, mimickers of juvenile idiopathic arthritis. Dr. Kamran Mahmood, Senior Consultant Pediatric and Adolescent Rheumatologist from SKMC Abu Dhabi, UAE. Our moderators are Dr. Kalpana Sengupta, Senior Consultant Pediatrician and Head of Department at NMC Specialty Hospital Al Nahda, Dubai, and Dr. Diari Muhammad, Senior Consultant Pediatric Surgeon at Al Jalila Children's Hospital, Dubai. They are moderating the session. Well, about our hero, Dr. Kamran Mahmood. Dr. Kamran Mahmood is a UK-trained pediatric and adolescent rheumatologist. He was awarded the best trainee of the year during his training. As a consultant at Alder Hay Children's Hospital, he was awarded with Clinical Excellence Award for 3 years in a row. Please note, 3 years in a row. Dr. Kamran has a huge academic portfolio and published more than 35 papers in the peer-reviewed journal. He has a vast research experience and conducted many studies. Dr. Kamran was one of the UK leads in inflammatory bone diseases group. Along with research and clinical work, Dr. Kamran has a huge interest in medical education. He regularly teaches on children's safeguarding and has helped a lot of trainees on their career as RCPCH college tutor. He is currently working as a consultant, pediatric and adolescent rheumatology at Sheikh Khalifa Medical City, Abu Dhabi. Well, with this, my references, beautiful Dubai. Those who have not seen, come and see. I end here. Now I request Dr. Kamran to start his talk. After Dr. Kamran's talk, I would like to request all viewers to write the question and Q&A box. Then we will start the session on Q&A. Dr. Kamran, please.
Thank you very much for your kind introduction. Let me share my slides. Okay, Dr. Sarab, is it working okay?
Yes, yes, please.
Okay, brilliant. As Dr. Saurabh has very kindly introduced me, I'm really flattered. I'm Dr. Kamran. I'm consultant pediatric and adolescent rheumatologist, and it's really a pleasure, a privilege to speak to you guys, not just in UAE, but from all over the world. I can see the numbers are increasing already on the webinar. So today we'll be talking about mimickers of JIA, because from very beginning in my training, I thought that people always think that if there is joint pain and swelling, that automatically means it's inflammatory arthritis. However, it's not always the case. So just a brief overview about inflammatory arthritis. In UK, the prevalence was 1 in 1,000, and a total of 12,000 children were registered in JIA registry. The prevalence is not very different in Middle East and rest of the world, and it ranges from 1 to 1.5 in 1,000. A very important thing to remember that JIA, juvenile idiopathic inflammatory arthritis, is a diagnosis of exclusion, and that's why it has idiopathic in between the name. So the other known conditions are excluded. It has to be under 16 years of age, and the disease duration has to be more than 6 weeks. So if you send me somebody with a history of 4 weeks, I most likely will send them back with investigations and review them again after 6 weeks to make a diagnosis. And there has to be arthritis or enthesitis in one or more joints. And arthritis, by definition, is an inflammation inside the joint. It's not inflammation in the muscle or bone. It has to be inflamed synovium and inside the joint. And there needs to be symptoms of pain, swelling, warmth, and restriction. So these are the current subtypes under the umbrella of JIA, although I believe in next couple of years we will move on to next classification where you will not see systemic onset JIA as part of JIA group. It will move on into a separate group of autoinflammatory disorders. But currently we have oligoarthritis, where you have arthritis in 4 or less joints, polyarthritis, which is divided into 2 subtypes, rheumatoid factor positive and negative. So these are the arthritis in 4 and more joints, and related arthritis, where you have enthesis and axial arthropathy involved. Psoriatic arthritis needs to be arthritis with with either psoriasis in the subject or in first degree relative. And then systemic onset JIA, which I think most of you got familiar, especially since COVID period, which is associated with systemic hyperinflammatory responses. And then we have a subcategory of undifferentiated arthritis, which is arthritis associated with inflammatory bowel disease, with cystic fibrosis, with celiac disease, with metabolic disorders, and with many other conditions. So diagnosing arthritis can be a tedious job, and it doesn't come always with a simple swollen knee, no history of trauma, history of swelling for 6 weeks, and early morning stiffness. A lot of time we have to do detective work to go through all these possibilities, which I'm sure all of you have seen every now and then. But today we'll be focusing on the JIA differentials, which relates with the metabolic and metabolic or inherited disorders of metabolism. So I will be presenting you a few cases, and then we'll be going through the pathologies of these cases to highlight the importance and the importance of recognizing these mimickers when dealing with patients with inflammatory arthritis. So our first case was a male boy presented, a boy presented at age 2 years of age in August 2007. At presentation to pediatric rheumatology, already had chronically swollen, restricted right wrist, with no features of trauma or sepsis. At that time, ultrasound, musculoskeletal ultrasound was not widely available, and the initial investigations usually involved either X-rays or MRI where it was available. So initial X-ray showed irregularity and sclerosis of carpal bone, suggestive of active inflammation. He was treated with intraarticular steroid injection and has actually received injection twice with no significant benefit. So up till now, we have a 2-year-old boy with monoarthritis, no evidence of infection, and by exclusion, it was inflammatory arthritis. Imaging was supportive. So first line of treatment for inflammatory arthritis in monoarthritis or oligoarthritis is intraarticular steroid injection, which this child received. His follow-up imaging showed an evolving and grossly destructive arthropathy of right corpus and proximal phalanges. So we'll go through series of X's. This is his X-ray on the at age 2, where you can see that there is very limited, reduced joint space, and the carpal bones doesn't look very normal, and the this joint space looks very reduced. At age 3, you can see a huge difference on the right side. The joint space was much smaller, and the carpal bones were looking flattened, and there were erosions on the carpal bones that you can see. This region compared to this, compared to left side, on the right side, there is very little joint space left, and there are irregularities of the bones and erosions. At age 4, this became even more minimal, and the destruction of bone on the right side, carpal bone, has become much more significant. Age 5, this continues to progress. As you can see, almost no space left. At age 6, the child started developing pain symptoms in his feet as well. And this is a picture of his foot X-rays, where you can see similar type of changes on the left side as well. Now, age 6, his wrist X-ray, there was almost no joint space left, and carpal bones were almost diminished. And then we had a huge gap in the imaging because not much happened during that time, apart from supportive treatment. At age 13, the right wrist joint was almost destroyed, and there was no carpal bone left, and the joint space was almost diminished. And by that time, his left wrist was also very much destroyed. So the biopsy of the right wrist showed non-inflammatory fibrous adipose tissue. Subsequently, he presented with left midfoot swelling that we have seen the X-rays. And after genetic investigation, a mutation in MAFB gene confirmed the diagnosis of multicentric osteolysis. MAFB is a negative regulator of Rankel-induced osteoclastogenesis, which means that it reduces MAFB expression. The reduced MAFB expression will promote osteoclastogenesis. So this child had significant osteoclastic activity in his bones. This is a pictorial expression of Rankel pathway, and there you can see how it works in Rankel receptors and how the gene expresses the expression. It's a rare group of disorders. It includes multicentric carpotarsal osteolysis, which our patient had. But there is also a syndrome called MONA, which is multicentric osteolysis, nodulosis, and arthropathy. The cases are inherited, like many metabolic conditions, and usually there are mutations in MMP, MAFB gene, or they can be sporadic. Peak incidence in young age, usually under 10 years of age, and most commonly it affects carpal and tarsal bones. These patients can and may or may not have facial dysmorphism based on bone involvement, and these patients may or may not have nephropathy and renal involvement. Initial presentation is usually with restricted wrist and ankle movement. So wrist and ankle are similar joints in upper limb and lower limb. And there is, for some reason, both of them get affected. Significant pain, but no inflammatory element, i.e. there's no early morning stiffness or joint effusion. So the surprising thing was this patient presented with erosive arthropathy and there was no effusion in our patient's case as well. Mona additionally presents with deformities and contractures of hands and feet, along with nodules. The lab markers for inflammation are almost always negative. Autoantibody screens such as rheumatoid factor, anti-CCP, and HLA-B27, ANA are usually negative as well. And X-rays usually show osteopenias and osteolysis. So clinical progress in these patients usually leads to progressive destruction of carpal and tarsal bones. It can occasionally involve other bones as well. There is no proven effective therapy at the moment. Our patient is on denosumab, which is a anti-osteoporosis biological agent. It blocks the antibody to the ankle, therefore it should inhibit osteoclastic activity. I have to admit that our patient didn't have much benefit from denosumab. There are remedies such as vitamin D and bisphosphonate. Bisphosphonate is especially used for pain symptoms. Moving on to our second case, an 11-year-old girl who presented with a 5-month history of pain in the index fingers worse after writing, ankle pain with early morning stiffness, but no constitutional symptoms, so no weight loss, no fevers, no rashes. Of note, her mother had very long-standing history of joint problem, which started for mother when she was age 7, started with finger swelling and pain. Now she had flexion deformities of all of her fingers, and subsequently she ended up receiving bilateral hip replacement as well. 2 of her maternal uncles also had hip joint and finger problems. So I was very interested in finding that family history, and I asked mother to bring her X-rays as well. So on examination of that girl, her index finger metacarpal joints had loss of end range of, loss of end range of flexion with no evidence of inflammation. Elsewhere, she was generally hypermobile, that she was more flexible. Her investigation showed normal inflammatory markers. Autoantibody screen was negative, and X-ray showed some bony erosions. So this is her mother's X-rays, where you can see the bones are very abnormal shaped, with the phalanx look very abnormal. So based on this X-ray, when we shared with our musculoskeletal radiologist, a diagnosis of multiple epiphyseal dysplasia was proposed straight away. And this is a child's X-ray where you can see the early changes of very similar dysplasia can be seen in this child's phalanx as well. So multiple epiphyseal dysplasia is a part of a group of disorders called skeletal dysplasias. It's a general term for the disorder of development for bone and cartilage. Specifically, multiple epiphyseal dysplasia is a heterogeneous genetic condition, and there are at least 6 gene mutations are reported. It presents with very variable phenotype. Patients are usually normal at birth, and they can develop normally, but usually have mild to moderate short stature, joint deformities, abnormal gait, and early onset osteoarthritis. So after diagnosing this girl, we helped her mother to get diagnosed with multiple epiphyseal dysplasia, which helped her to come off immunosuppression that she has been on for many years. The other type of skeletal dysplasias is PPRD, progressive pseudorheumatoid dysplasia. It's a rare autosomal recessive disorder, most common in Asian and Arab population. In fact, I recently diagnosed a young boy with PPRD, who was originally from Dubai, and has been on immunosuppression. So now he's just on rehabilitation and physiotherapy. The initial clinical picture in early childhood is usually with fixed flexion contractures, early morning stiffness, especially in interphalangeal joints, metaphyseal bony overgrowth, and it usually presents with symmetrical pattern, and you usually see similar changes on both sides. Later on, children develop abnormal posture, disproportionate short stature, hip joint deformity and stiffness, and kyphoscoliosis with hyperlordosis. It's relatively common for PPRD patients to get diagnosed as ankylosing spondylitis. In fact, 5 or 6 years ago, I diagnosed two siblings with PPRD who were on treatment for ankylosing spondylitis and were receiving adalimumab. And after the X-rays and MRI and other investigations, we diagnosed them with PPRD. So it's one of the differential diagnoses of rheumatoid positive polyarthritis, and very important to consider, especially in our region. PPRD, the axes are usually quite typical. They show the widening of flanges, and you can see the almost square-shaped epiphysis. Inflammatory markers are usually normal, and there is no curative treatment. However, early diagnosis can lead to early physio and occupational therapy input, which can improve the mobility and pain symptoms in these patients. This is another picture of a young child with PPRD, and this is another X-ray of a young person with multiple epiphyseal dysplasia, where you can see brachydactyly and squaring of epiphysis. So moving on to our third case, 1-year-old boy, Irish mother and Malaysian father, presented with pericarditis, episodic spiking fever, and no rashes. This child at that point was treated and got better, and then years later developed a polyarthropathy, which started with finger flexion. At onset, the inflammatory markers were high, which normalized on all other occasions. Initially, child was ANA positive, 1 into 160, so not very high, not very strongly positive, and subsequently became negative. The child was rheumatoid factor negative. So based on pericarditis and possible arthritis, the child was diagnosed with systemic onset JIA at the beginning, and the steroid treatment there was complete resolution of pericarditis and fever. For persistent arthropathy, there was obvious synovitis, inflammation of the synovium. There were effusions, which was usually cold. Normally, when we see active arthritis, it's usually warm, but this patient had cold collections, and there were marked contractures in all the joints. The child was significantly disabled with early morning stiffness up to 2 hours, unable to walk for longer distance, had to use crutches, and missed a lot of school. This child received multiple immunosuppression, including methotrexate, long courses of steroids, lots of pulses of steroids, and multiple biologics, and was then we were planning to refer him to stem cell transplant, which is the treatment when children with inflammatory arthropathy they do not respond to multiple biologics. At that time, one of the clever colleagues reviewed all the notes to make a summary for stem cell transplant recommendation letter and reconsidered the diagnosis. So this child actually had camptodactyly arthropathy, Coxa-Vara pericarditis syndrome, CACP. It's a rare autosomal recessive disorder. Causative gene is chromosome 1. and codes for PRG4, proteoglycan 4, a surface lubricant for joints and tendons. It's characterized by camptodactyly, which is fixed flexion deformity of PIP joints, arthropathy, which is painless swelling, which presents as a painless swelling of interphalangeal joint, knees, wrists, with almost normal range of movement and no inflammatory symptoms, i.e., no early morning stiffness, no pain at rest. With or without progressive coxa and with or without non-inflammatory pericarditis or pericardial effusion. Interestingly, a few months ago, I saw a 6-month-old who had camptodactyly, whose mother was a healthcare professional who looked at her fingers, her child's fingers, and thought that they don't look normal, and went for whole exome sequencing. And the child came back camptodactyly, arthropathy, coxa pericarditis syndrome because of positive gene for PRG4. Now, this child only had camptodactyly and no other symptoms, so we're just keeping him under surveillance. So in CSCP, you can see the joint spaces are usually preserved and with the normal carpal bones, but you can see there's squaring of the metacarpals very similar to epiphyseal dysplasias and the periarticular osteopenias. Coxa is a smooth flattening of both the femoral head and bilateral acetabular cyst, which are much better visible in the MRI scan. So for CSCP, usually the normal inflammatory markers are normal. One can see synovial thickening and effusion on both ultrasound and MRI. However, on biopsy, there are non-inflammatory changes with multinucleated joint cell infiltration. Hip X-rays showed flattening of femoral heads and short femoral necks with coxa, and hip MRI shows intraosseous acetabular herniations communicating with the effusions. So this is how you see the intraosseous herniations communicating with the effusions on the MRI. Treatment of CSCP, which is a non-inflammatory condition, is unfortunately symptomatic and physiotherapy. So occupational therapy and physiotherapy for joint derangements and symptomatic treatment of pericarditis. Case 4 is a 7-year-old female who presented with joint pains for 12 months. On examination, she had combination of warm joints with few restricted large joints. Radiologically, she had radiological hepatosplenomegaly, which was known for 3 years. First noticed during holidays when she developed diarrhea and vomiting, and since then she was investigated by a general pediatrician in her region, had serial ultrasound and serial blood checks, which were completely normal, and infection screen was all negative, and there were no changes in her and liver and spleen size. There was strong family history of JIA and uveitis, and in fact, her mother was under our adult rheumatology colleague and was taking Humira adalimumab injection. So an initial diagnosis of polyarticular JIA was made pending bone marrow aspirate, and her bone marrow aspirate showed wrinkled foamy cells. So I like you guys to write what pathology is associated with wrinkled foamy cells, and after the next couple of slides, you can see if your answer was correct or not. But I've been told by a pathologist that this is what the wrinkled foamy cell looks like. So wrinkled foamy cell is a diagnostic feature, probably a pathognomic feature in bone marrow for Gaucher's disease, which is a lysosomal storage disorder. It's an autosomal recessive condition with mutations in GBA gene, which leads to reduced levels of beta-glucocerebrosidase. Pathology is developed from glucocerebrosidase buildup. It's a multi-system disorder. Type 1 is the most common type, which is non-neuropathic, had variable severity, and can present in child or adulthood. Type 2 is associated with early death, and type 3, which what our patient had, is neuropathic type. Type 1 is strongly associated with skeletal manifestations, primarily involving long bones and vertebrae, growth retardation, bone pain, These patients can present with acute bone infarctions and bone crises and necrosis. And they have reduced bone density and can present with pathological fractures. These patients usually have widening of bones above the knee joints, and they almost always develop kyphosis and chest wall deformities. They develop bleeding and pancytopenias, generally very fatigued and tired, and has loss of appetite, and there is significant hepatosplenomegaly. This is a picture of one of the babies with active Gaucher's disease, and you can see significant ascites and hepatosplenomegaly. So the bones, long bones in Gaucher's disease can look like with Erlenmeyer flask deformity, where you can see this is the normal bone, where you have a picture like this, and the bone in Gaucher disease can look like a Erlenmeyer flask, the flask that we use cutting tea and kava in the morning sessions. So the diagnosis of Gaucher should be suspected based on history, examination, and lab test, as well as radiology. It is confirmed with glucocerebrosidase activity in leukocytes or fibroblasts, which is the gold standard for diagnosis, and genetics to identify the mutation. Enzyme replacement therapy is very beneficial when started early for type 1 and most type 3 individuals. Bone marrow transplantation also rarely used. A little bit about mucopolysaccharidosis, inherited inborn metabolic disorder of glycosaminoglycan breakdown. There are 7 subtypes. Type 1 is commonest, severe form is Hurler's, and the mild form is Shy syndrome. Age of presentation can be less than 1 month to 39 years of age. It's a multi-system disorder, leads to progressive symptom due to GAG accumulation in tissues and organs. And unfortunately, a good number of these patients can present to rheumatology clinics first before they present to metabolic clinics, because the predominant symptom of stiff joint and skeletal abnormalities. In patients, usually these patients end up seeing 4 to 5 different specialties, including rheumatology, prior to presenting to metabolic or prior to being referred to metabolic consultants. So this is a picture from from textbook of rheumatology, where you can see an elderly person which hand showing a lot of deformities and changes, which would look very similar to a rheumatoid hand, but actually this patient had Shay syndrome. Mucopolysaccharidosis can be screened with urine MPS screen, enzymatic activity, and treatment is enzyme replacement therapy and stem cell transplant. Early treatment and early transplant has better yields, and disability and premature death is the complication. Few other genetic mimics of JIA. One relatively common one is Stickler syndrome, which is a collagen disorder. These patients have very distinct facial appearances, and they have eye abnormalities, including glaucoma, cataracts, retinal detachment, and sometimes these patients get diagnosed because of the ongoing changes in their eyes. And they usually have hearing loss, and the joint problems are usually initially from hypermobility and mechanical pain, and later on they develop arthritis especially in smaller joints. Then we have lysosomal storage disorder, especially Farber's, which is often presents under 4 months of age. It presents with painful swelling of many joints. Nodules under the skin in relation to the affected joints can be misdiagnosed as rheumatic nodules. These patients usually have post-cry. So the key learning point that all joint pains, with or without swelling, are not inflammatory. So we have to have an open mind about patients when they present. Genetic mimickers of JIA can have very subtle symptoms initially, and it's very important to identify, because these patients, if they get a diagnosis of JIA, it will take a long time to reverse the diagnosis, and they will end up receiving a lot of immunosuppression. Secondly, a right diagnosis early on will lead to right treatment, which can have catastrophic effect if it delayed, especially conditions like MPS. And one has to remember to make a diagnosis of inflammatory arthritis, there has to be clinical and radiological evidence of synovial inflammation. So this is a very good website, pmmonline.org. It's available in many different languages, and it has lots of sections for doctors, healthcare professionals, nurses, and medical students. So I strongly recommend those who have interest in rheumatology to use this website as your aid. Always ask about family history, including consanguinity. I don't need to tell anybody in this region because that's the bread and butter here. And think about surgical sieves. So inflammatory, non-inflammatory, metabolic, iatrogenic, malignancy, always include these in your differential diagnosis. And if something doesn't fit, then pick up a phone and give somebody a call. There's help always available. Reevaluate your patient and use radiology MTTs. These are very, very important. Radiologists are a huge source of information, but you just need to give them right information when you're discussing imaging with them. These are my references. Thank you very much.
Thank you very much, Dr. Kamban, for this excellent presentation. I would like to request all viewers to write their questions in Q&A box so that our moderators will start the session. Now I would like to request Dr. Diari, Dr. Kalpana to join. Till question come, actually, Dr. Noor, one of our senior pediatrician and a member of the Pediatric Club, has asked some questions. One question I want to ask you, Dr. Kamran, what are the common cases where pediatricians should not miss, office pediatrician? Because majority of viewers are the office pediatrician. So what are the cases they should not miss in the office related to this idiopathic juvenile arthritis? What are the cases to be kept in mind, which cases to refer to you? In nutshell, if you tell us, please.
So I think in general, obviously it's a difficult question to answer because the limitation of how much you can do in the clinic setting. But generally, where you have patients with unexplained pain and swelling, which doesn't fit with with infections, which doesn't fit with reactive arthritis, and you're already reaching towards 6-week window for inflammatory arthritis, then these patients should be referred. Usually patient with acute pain and swelling, even if they come to us, we would ask them to see orthopedic surgeon first to get septic arthritis excluded. So if that's the case, if it's very, very acute setting within like 2 or 3 days or less than a week, and there is a vague history of trauma, then better to get orthopedic opinion. But if it's atraumatic, no injury involved, atraumatic pain and swelling with multiple weeks, then better to refer to us. Secondly, patients who have prolonged fever or intermittent fever with joint swelling and unexplained rashes. So patients who have unexplained weight loss or unexplained rashes, especially photosensitive rashes, no explanation for dropping their counts, but and these type of patients who can fit with a lot of conditions that we see, for example, lupus or Behçet's or dermatomyositis. So early referral for these patients are very helpful. What I would recommend is to avoid checking out antibodies because a lot of people do them to be helpful. So by the time we see the patients, we have the results available. But unfortunately, a lot of these patients will come to us with positive antibodies. And by the time we see them, the symptoms are resolved. And then it becomes very difficult to reassure them that what they had was reactive. One must remember that these antibodies can be positive when someone has viral or bacterial infection. They can be positive associated with other conditions. So I have a number of patients with anticentromere antibody positive who have an underlying diagnosis of celiac disease, and they do not have scleroderma. But somebody checked their ENA and they have persistent anticentromere antibody positive. Now I'm keeping them under surveillance because it's such a catastrophic diagnosis to miss. Patients who have prolonged and unexplained bone pain and joint pain definitely need to come to us for screening. And generally, I don't mind any referral. If when I see them, If they are not under my specialty, if they don't belong to me, I usually tell them and refer them back.
Thank you very much. I'd like to welcome Dr. Kalpana. Dr. Kalpana was not feeling well. So kind of her to join us. Dr. Kalpana, please start.
Thank you, Doctor. Thank you, Dr. Kamran, for a wonderful session. However, I must acknowledge that these cases are, very specialized ones. And probably I would like to learn from you, are they rare in rheumatological practice as well? Or you do see them fairly commonly?
So you're absolutely right. These are very rare cases, and the one good thing about their specialty is that what is rare in general public is not rare in that specialty. So JIA is probably rare in general pediatrics. So you will not see a JIA patient every day, but for me, I will probably see at least 1 or 2 JIA every week, if not every day. However, the cases that I presented, these are rare cases. So I have seen one CSCP patient in UK and one CSC patient in UAE. And I've been consultant for around 10 years now, and in training and doing rheumatology for about 20 years now. So in 20 years, I've only seen 2 patients. And you know that in UK, there's a lot of Middle East population as well. But still, CSCP only 2 patients. Epiphyseal dysplasia, I have seen many, and that's because I did inflammatory bone disease clinic as well. And in UK, there's a lot of Asian population from Indian and Pakistani origin, and epiphyseal dysplasia is relatively common. However, I've seen only 1 PPRD patient here in UAE and 3 PPRD patient in Pakistan, where I don't normally practice. I only go and teach and see difficult patients, and during that session, I diagnose them. So these are very rare patients, so you don't need to worry about them in your day-to-day practice. But in your day-to-day practice, there is no guarantee that one of them will not turn in your clinic. So, for example, that CSCP patient that I see here in Abu Dhabi was not diagnosed by me. Her mother was very clever. She noticed that the newborn has bendy fingers. It doesn't look normal. And because of availability of genetic testing, she went for whole exome sequencing, and she got a diagnosis. Now, problem for me is that the child doesn't have any problem. The child doesn't have pericarditis. The child doesn't have any hip abnormalities, and there's very little I can offer them apart from seeing them, which is a bit boring thing for mother. But at least we can pick up her pericarditis early and treat her.
So, yeah. So there are a couple of
a
questions.
question.
Yes, doctor. Go ahead.
Kamran, there is a question from Dr. Mahmoud. What is the difference between Still's disease and JIA?
So you probably noticed that I haven't used the word still disease in my JIA talk whatsoever. Still disease is adult equivalent of systemic onset JIA to the nearest. So we do not use that term in pediatrics anymore. Still disease is where you have features of inflammatory arthritis associated with systemic inflammation, and especially they have hepatosplenomegaly and element of macrophage activation syndrome. But in younger children, systemic onset GI usually presents with fever, quotidian rash, which comes with fever, and evanescent rash, which comes with fever, and quotidian fever, which comes with a pattern. And these are the patients that we do not wait for 6 weeks to diagnose them, and we diagnose them when we see them with the typical presentation, because these patients are very sick, and they can lead into macrophage activation syndrome and life-threatening complications very quickly. So a lot of people, adult rheumatology still uses the acronym adult onset still disease as a systemic GIA equivalent. And I believe in PRINTO, which is Pediatric Rheumatology International Trial Organization, is working on new classification of GIA, where you will see the systemic onset GIA will be taken out of GIA classification and will move into a separate panel of autoinflammatory conditions. Systemic JIA is and still disease is considered as autoinflammatory, while the rest of the inflammatory arthritis is considered as autoimmune condition.
So there was a question from Dr. Noor. Simple approach to differentiate between autoinflammation and autoimmune disease. Do you have any?
So it's the simple approach is going back to the basics, but it's very difficult because we can define them as autoinflammatory and autoimmune condition, but a lot of features overlap. So sometimes it's very difficult to look at the symptoms and say that this child likely to have autoinflammatory or autoimmune. But autoinflammatory conditions are the conditions associated with problem with the innate immune system. While autoimmune conditions are associated with problem with your adaptive immune system. So if you see somebody has antibody positivity, they're very unlikely to be autoinflammatory because you develop autoantibodies from your adaptive immune system. So they are autoimmune conditions. So usually autoinflammatory conditions are, they present soon after birth, and they involve what we call the defense system of the body. So newborn defense system is not the immune system. It's usually the skin and hair and the external and the mucosal membranes. So usually autoinflammatory conditions have significant skin involvement, rashes, mucosal involvement, and ulceration. So conditions like pediatric fevers, FMF, TRAPS, Behçet's, these are some examples of autoimmune condition. And autoimmune conditions usually present a little bit later. So very unusual for a JIA patient to present before 6 months of age. So JIA usually after 6 months of age. The youngest JIA I have seen was 11 months. So usually these patients are a little bit older. They usually have, so autoinflammatory patients usually have high fever and continuous fever in periods, while autoimmune usually low-grade fever, which comes and goes and can present with the episode of illness. So autoimmune conditions, some examples are inflammatory arthritis, dermatomyositis, lupus, for example, scleroderma. These are autoimmune conditions where you see very strong autoantibody profile.
There's a question from Dr. Hadi Faki asking, do you consider familial Mediterranean fever as a JIA mimicker?
Yes, indeed, it is one of the JIA mimickers. But I think one of the reasons that I didn't present it because FMF is more a systemic JIA mimicker. And it's actually relatively common here. I have seen a lot of FMF patients diagnosed by general pediatricians and sent to me for IL-1 blockade. So I didn't think that it would be a very exciting pathology to discuss, but FMF is definitely a mimicker of inflammatory arthritis, but more towards systemic JIA.
How commonly have you seen dermatomyositis in UAE?
So I personally have in SKMC, I have about 10 patients, which is a big number accumulated over 3 years of age. To give you an example, Al-Dahay Children's Hospital, Liverpool is the largest rheumatology center, not just in UK, in Europe. And we were 11 consultants altogether in Al-Dahay. And between all of us, we had 25 dermatomyositis patients from almost all over the UK. So considering that a population of 10 million in UAE and 10 patients only in one center over a period of 3 years is a big number. So I think there are significant number of patients probably being treated by a dermatologist or adult rheumatologist and not yet seen the pediatric rheumatologist, because I think 2 of my patients came because their cousin got diagnosed and they were under adult rheumatologist, then they moved to under me. And 2 of my patients came because the mothers were under adult rheumatologist, and then they asked their children to come under our service. But it's not an uncommon condition. In pediatric rheumatology clinic, we see 1 patient every 2 to 3 months, which is not an uncommon thing.
Okay. Dr. Ghulam Mustafa compliments you on the presentation and wants to know that for your first case, the mutation that was found, can it be picked up on whole gene sequencing, or do you need to specify certain mutations?
That's probably genetics to answer, but my limited knowledge of genetics, because we work very closely with genetics, especially since I moved here, we have lots of pediatric fever and FMF patients. I don't see why it shouldn't be picked up in whole exome sequencing.
Okay, so I suppose he wants to know whether to order whole exomes sequencing or to specify. So it can be picked up if you order.
Yeah, but if I'm honest, I would probably give a call to genetics first.
Okay.
So there is a question: when to suspect rheumatological disease in atypical presentation in practice?
So when you see, so there are a few things when you see patients. If you ask them about pain, usually rheumatological conditions, inflammatory conditions have pain at rest, and mechanical conditions have pain with the working. So if somebody tells you that my child is very stiff in the morning, as the day progresses, they get better, then you must consider inflammatory arthritis as underlying possibility. Similarly, if you see unexplained rise in inflammatory markers without any episodes of fever, if you see patients with recurrent episodes of fever, if you see patients with recurrent oral and genital ulceration, if you see patients with photosensitive rashes, if you see patients with alopecia, unexplained hair loss, if you see, pain in patients with eczema and psoriasis, usually associated with underlying inflammatory arthritis. So I usually tell my patients that rheumatology is a specialty of inflammation, and by that definition, we deal with almost all the organs in the body from top to bottom, and actually inflammation from anywhere in the body we are linked. So I do a joint clinic with our neurologist here, where we see inflammatory brain disease patients, which is a very unique type of inflammation. So unexplained, uncontrolled seizures with high fever usually get referred to us for joint clinics as well. And we have a few patients diagnosed with fires after being referred from other specialties. Autoimmune encephalopathy is another example where patients got referred to neurology and we got involved and we treated them with immunosuppression with reasonable results. So wherever you have unexplained inflammation, inflammatory pain, unexplained rise in inflammatory markers, I think it's reasonable to think about a rheumatologist. And I have to mention that if you see somebody who's ANA positive with very low titers, like 1 into 80 or 1 into 160, this can be just a transient phenomenon and doesn't have to be related with inflammatory arthritis. But the key thing is to know when it was done. If it was done when somebody had viral infection and joint pain, like sore throat and joint pain, then it's probably best to be repeated again after 6 weeks. And a lot of time I see patients who were treated with IVIG for Kawasaki, and somebody checks their antibodies because they had joint pain and they have lots of antibody positive. So you need to remember that after IVIG, you cannot check out antibodies for 3 months, ideally 6 months, but at least for 3 months, because you will get a false positive result from IVIG. So just bearing these things in mind. But there are, not all the rheumatology patients will present to your clinic with, warm swollen knee for 6 weeks without any evidence of trauma or infection. So it will be your job to screen these patients with the signs and symptoms that we discussed to get them referred to our clinics.
So what's the basic investigation that the general pediatrician allowed to do? Or you, on basis of clinical, you want to refer to some specialized people like you?
No, I think they should do, they can do everything. There's no restriction, but it's better to start with baseline, like, blood counts, inflammatory markers, urine protein creatinine ratio. And you need to do your investigation based on what you are thinking. So, for example, if you're thinking of lupus, inflammatory myositis, then you will check CK, you will check urine protein creatinine ratio, and there's no harm in checking out antibodies. But if you have a patient with joint pain, and there is very little to find, then I would suggest do basics like, blood counts, thyroid function test, CRP and ESR. And if they have unexplained high ESR, then you should send them to us, because there's no reason why somebody with mechanical pain should have high ESR.
Right. I think there are a couple of questions on JIA now. Dr. Rai Chaudhary is asking about the use of biologics in treatment of JIA.
So biologics have transformed treatment of inflammatory conditions in last 30 years or so. And now patients, remission was something that was unheard of in rheumatology. Now almost all our patients are in remission. So we use biologics relatively aggressively and relatively early now, but we don't start anybody on biologics straight away, because there is absolutely no need to treat somebody with the maximum immunosuppression when we can treat them with something as simple as methotrexate. However, if we don't see a response in 3 to 6 months, usually soon after 3 months, we move on to biologics. Usually we start with anti-TNF first, and if we don't have a response, then we have options of moving to IL-6 blockers. If that doesn't work, then we have anti-CD20. If that doesn't work, we have co-stimulatory such as abatacept. So there are lots and lots of options available now.
Right. As pediatricians, we very commonly consider the diagnosis of systemic JIA when we get a case of pyrexia of unknown origin. So, would like to have some pointers from you, clinical pointers, and then, because quite often rheumatological diseases are evolving and only subsequently on follow-up do we end up diagnosing them.
So if you follow the textbook, systemic onset GI patients should have a pattern of fever. So they should have fever 2 times a day or 3 times a day or 4 times a day. Usually they have a evanescent rash, a salmon pink rash that comes with fever and goes away when fever settles. Usually when they scratch them, or if you scratch their legs or tummy or arm, you can see typical Koppner's phenomena. You can see the typical lines developed. They usually have hepatosplenomegaly. They usually have things like night sweat. They usually look miserable, very similar to lymphoma, leukemia. But in terms of blood test, you will see the difference would be thrombocytosis rather than pancytopenia. So usually with malignancy, you will see pancytopenia and dropping counts. In systemic GI, you will see anemia with thrombocytosis. Similarly, you will see high ferritin, and any patient with ferritin out of proportion for CRP and ESR. So if you have CRP of 100 and ferritin of 5,000, that's out of proportion. But if you have CRP of 100 and ferritin of 300, that's comparable. So any hyperferritinemia along with these conditions, systemic GIA should be considered. And it's a diagnosis that one should not waste time and refer them urgently, because these are the patients who can deteriorate very quickly, decompensate very quickly, and because they mimic so much with infection that a lot of people will struggle to give them steroids, and it's the steroids which will make them better very quickly and save them from going into life-threatening complications. One of the, not scientific, but one of the tricks that I learned when I was training with Professor Ramanan in Bristol, that if you do the temperature chart for these patients upside down, so usually you see the temperature spikes for patients who are febrile, but you don't see the similar spikes other way around for hypothermia. But systemic GI patients, between episodes of fever, when you give them antipyretic, you can see almost similar spike of hypothermia. So from 38, they can go to 36 or 35.
There is a question from Dr. Abdul Rahim. Do you consider, I don't know what's the abbreviation of CRMO, CNO, spinal cord tumor